Now we start with the first session of the morning. And in this, we'll be dealing with left main cases and treatment dilemmas with regards to left main cases, isolated circosteal or LED osteal, and obviously bifurcation stenting. And we have got an elite panel of experts to be with us for this session. So first of all, I'll request the local panelists to come to the stage so that we can start. So may I request Dr. Muhammad Noori, who is the ex-commandant of Armed Forces Institute of Cardiology, to be with us for being the panelist for the session. Then General Retired Azhar Kiani, he is the ex-commandant of AFIC. Also, he is the ex-chief executive of Rawalpindi Institute of Cardiology. Then I'd like to invite Dr. Harun Babar Khan, if he is here. Then Asad Akbar Khan, he is the chief of cardiology at Shifa International, chief of interventional cardiology and structural heart program at Shifa International Hospital. Then Professor Numan Nasir, he is the chief of interventional cardiology at Beria University Hospital, Lahore. Then Dr. Ahmed Fawad, if he is here, then he can join us. Dr. Tariq Shafi, can you join us for the panel, to be among the panel? Now we are joined by two eminent interventionalists from USA. First of all, it's my pleasure to introduce you Dr. Ramesh Dagabuti, who is interventional cardiology chair at West Virginia University. And then Dawn Abbott. She is on the editorial board of Sky, as well as very eminent cardiologist in USA. So these are the international panelists joining us. And first of all, we'll be moving on to a live transmission. It will be done by Dr. Ehtisham Mahmud. And let me introduce Dr. Ehtisham Mahmud is the ex-president of Sky. And he natively belongs from Lahore. And he migrated in late 80s to US. And obviously he has achieved all the heights there. So he is currently the head of cardiology at University College, California. And Dr. Ehtisham Mahmud with his team is there. And we welcome all of them. And let's move over to Dr. Ehtisham Mahmood's lab. Welcome, Ehtisham. I am Professor Zubair Akram. How are you, Ehtisham? So you are live with us, and we have got panelists among us and all the leading cardiologists of the country there with us. So welcome from Lahore. Ehtisham, over to you.
Great, thank you. Can you all hear me? Okay, perfect. Hearing a bit of an echo, but thank you for the invitation. And can we go ahead and play the video, please? Just a quick introduction of San Diego and the University of California, San Diego. That's our Cardiovascular Institute. And as everybody gets a chance to see that, I will also quickly introduce my team here. I have my nurses, Isabel and Sophie, and Tech, Derek and Vernier. And to my left is my colleague, but our interventional cardiology fellow.
There is some distortion in your sound quality. Maybe you can adjust your mic settings because we can't hear you clearly.
So our patient is a 74-year-old female.
So Ehtisham, just try again. Maybe we listen to you now.
Can you see the slides?
No, we can't see the slides. We just see you in a box and the ECG, and maybe, just a femoral.
Oh, I see. That's what you're getting to see.
Actually, Ehtisham, this is Bashir. Sorry, when we see your slides, it's when both things are on, we are hearing echoing of your voice. So we had to use either the slides or, yeah, now we can see the slides.
Yep.
Okay. So our patient is a 74-year-old female with insulin-dependent diabetes, hypertension, chronic kidney disease due to diabetic nephropathy. She was referred to our hospital with new onset ischemic systolic dysfunction and angina on maximal medical therapy. Her medical regimen was amlodipine,
Ehtisham,
isosorbide
just try again.
mononitrate, and
Maybe we listen to you
metoprolol
now.
to maximal doses. She was on insulin and aspirin and
No, we can't see the slides.
rosuvastatin, and we loaded
We
her
just
with
see you in the
Plavix
box and the ECG,
after
and
her...
maybe,
Sorry, go ahead.
just a femoral.
Oh, I see. That's what you're getting to see.
Actually, Ehtisham, this is Bashir. Sorry, when we see your slides,
So you can move
when
to next
both
slide.
things are on, we are hearing echoing of your voice. So we had to use either the slides or, yeah, now we can see the slides.
Yep.
Okay.
It seems
So
you
our
are
patient
mute.
is a 74-year-old female with insulin-dependent diabetes,
Okay. Now we can see the
hypertension,
next slide.
chronic kidney disease due to diabetic nephropathy.
But we can't listen to you now.
Was referred to our hospital with new onset ischemic systolic dysfunction and angina on maximal medical therapy. Her medical regimen was amlodipine,
Ehtisham,
isosorbide
just try
It
again.
seems you are
and
mute.
Maybe we
You're
listen to
mute
you
on the.
now.
to maximal doses. She was on insulin and aspirin.
Yeah, now we can
No, we
hear
can't
you.
see the slides.
Now we
and
can hear you.
loaded
We
her
just
with
see you in the
Plavix
box and the ECG,
after
and
her...
maybe,
Sorry, go ahead.
just a femoral. Once again, your voice has gone.
That's what you're getting
Yep.
to see.
Actually, Ehtisham, this is Bashir. Sorry, when we see your slides,
So you can move
when
to next
both
slide.
things are on, we are hearing echoing of your voice. So we had to use either the slides or, yeah, now we can see the slides.
Yep. Okay, now we can see the echo
Okay.
images.
It seems
So
you
our
are mute.
patient is a 74-year-old female with insulin-dependent diabetes,
Okay, now we can see the
hypertension,
next slide.
chronic kidney disease due to diabetic nephropathy.
But we
She
can't listen to you.
was referred to our hospital with new onset ischemic systolic dysfunction and angina on maximal medical therapy. Her medical regimen was amlodipine,
Ehtisham,
isosorbide
just try
It
again.
seems you are
and
mute.
Maybe we
You're
listen to
mute
you
on the.
now.
to maximal doses. She was on
Yeah,
insulin and aspirin.
now we can
Yeah,
hear
now
you.
we can
Now we
hear
can't
you.
see the slides.
Now we
and
can hear you.
loaded
We
her
just
with
see you in the
Plavix
box and the ECG,
after
and
her...
maybe,
Sorry, go ahead.
just a femoral. Now we can see once again, your
Oh,
voice has gone.
you're getting
Yep.
to see.
Actually, Ehtisham, this is Bashir. Sorry, when we see your slides,
So you can move
when
to next
both
slide.
things are on, we are hearing echoing of your voice. So we had to use either the slides or, yeah, now we can see the slides.
Yep. Okay, now we can see the echo
Okay.
images.
It seems
So
you
our
are mute.
patient is a 74-year-old female with insulin-dependent diabetes,
Okay, now we can see the
hypertension,
next slide.
chronic kidney disease due to diabetic nephropathy.
But we
She
can't listen to you.
was referred to our hospital with new onset
The voice quality is not good. We can't hear you.
and angina on maximal medical therapy. Her medical regimen was amlodipine,
Ehtisham,
isosorbide
just try
It
again.
seems you are mute.
Maybe we
You're
listen to
mute
you
on the.
now.
to maximal doses. She was on insulin and aspirin.
Now we can hear
Now
you.
we can
Now we
hear
can't
you.
see the slides.
Now we can hear you.
Loaded her
Just
with
see you in the
Plavix
box and the ECG,
after
and
her...
maybe,
Sorry, go ahead.
just a femoral. Now we can see once again, your voice has gone. Yep.
to see.
Actually, maybe you can Bashir, your case. Sorry, when we see your slides,
So you can move to
when
next
both
slide.
things are on, we are hearing echoing of your voice.
Talking on the
So
phone
we had
or
to
you have a
use
mic?
either the slides or, yeah, now we can see the slides.
Yep. Okay, now we can see the echo
Okay.
images.
It seems
So
you
our
are mute.
patient is a 74-year-old female with insulin-dependent diabetes,
Okay, now we can see the next slide.
chronic kidney disease due to diabetic nephropathy.
But we
She
can't listen to you.
was referred to our hospital with new onset
The voice quality is not good. We can't try to reconnect,
and angina on maximal medical therapy. Her medical regimen was amlodipine, isopropyl monohydrate,
You are mute. You are on mute on
the maximal doses. She was on insulin and aspirin.
Now we can hear you.
Now
Now we can't see the slides.
Now we
And you
can hear
muted
you.
her with glucosamine
Not
after
and
her,
maybe,
sorry, go ahead.
just a femoral. Now we can see once again, your
Oh,
voice
I
has
see, that's
gone.
what you're getting to see.
Actually, maybe you can repeat your case now. When we see your slide,
So you can move to
when
next
both
slide.
things are on, we are hearing echoing of your voice. So we had to
So we have lost
either
your
the slides
voice
or
again.
yeah. Now we can see the slides.
Yep. Okay, now we can see the echo
Okay.
images.
It seems
So
you
our
are
patient is a 74-year-old female with insulin-dependent diabetes,
Now we can see the next slide.
chronic kidney disease due to diabetic nephropathy.
But we
She
can't listen to
was
you.
referred to our hospital.
The voice quality is not good. We can't try to reconnect,
and angina on maximal medical therapy.
We
Her
can't hear
medical
you
regimen
properly.
was
We can't see the
amlodipine,
slides. Ehtisham,
isopropyl
can't just
hear you.
monohydrate,
You are mute.
Maybe
You
we
are
can
on
listen
mute
to
on
you
the.
now.
the maximal. Can anybody hear me?
Yep. Not
Yeah,
very
we
clear,
can
but
hear you.
now,
Okay.
now we can hear a bit of.
Okay. You know, it kept playing the same recording. Let me show you where we are in this case. So this is the 74-year-old lady with ischemic cardiomyopathy, ejection fraction 25 to 30%. And we capped her 2 days ago. She had an ostial and distal left main. Also LAD that's occluded, distal circ is occluded. And the right coronary has a proximal lesion with right to left collateral. On the echo, she's got inferior akinesis, hypokinesis of the anterior and lateral wall. So let me just show you what we've done. I know. Can you hear me, everybody?
Yeah.
Yes.
Not too clearly, but still, now at least we can hear a bit of you. So it's a 74 years
Okay, well, I'm
old.
going to show you
Yeah.
74-year-old ischemic cardiomyopathy. Can anybody hear me? EF 25%.
Just show us the, not very clear, but now angio of the case, a bit of.
Okay, no, it kept playing the same recording. We went ahead where we are in this case, put an impella. So this is an ostial left main, cardiomyopathy, ejection fraction 25 to 30%. And I hear a lot of echo in the background. She has an ostial distal left main.
Yeah. Shami, can you hold? Maureen, can you please mute your phone?
And the right coronary has a proximal lesion with right to left collateral. On the echo, she's got inferior akinesis, hypokinesis of the anterior and lateral wall. So let me just show you what we've done. I know. Can you hear me, everybody?
Yeah.
Yes.
Not too clearly, but still, now at least we can hear a bit of you. So it's a 74 years
Okay, well, I'm going to show you
Yeah.
74-year-old ischemic cardiomyopathy. Can anybody hear me?
And it's not showing
Just
the
show,
computer.
just show us
So
the,
ask
not very
for
clear,
that.
but
Why is it
now
not
angio
showing?
of the case, a bit of. Varin, you are requested,
Varin,
you are requested to mute your phone.
So we went ahead where we are in this case, put an impella. So this is an ostial left main, cardiomyopathy.
So we have lost
ejection fraction 25 to
your
30%.
voice, we have lost the
I hear a lot of echo in the
any visual
background.
from
She has
your
an ostial
center,
distal left
Ehtisham.
main.
Yeah.
Can you see
Shami,
the
can you
image?
hold? Maureen,
No, we can't see.
can you please mute your phone?
And the
Maureen?
right
Can you
coronary
please start
has a
the
proximal
case
lesion
and
with
just
right
show
to
us
left
NGOs if possible?
collateral. On the echo, she's got inferior akinesis,
Ehtisham, can you hear us?
hypokinesis of the anterior and lateral wall. So let me just show you what we've done. I know. Can you hear me, everybody?
Yeah.
Yes.
Not too clearly, but still, now at least we can hear a bit of you. So it's a 74
Okay,
years
well, I'm
old.
going to show you
Yeah, yeah.
74-year-old ischemic cardiomyopathy. Anybody hear me?
it's not showing
Just
you
show us,
the
just show us
So
the,
ask
not
this
very
question,
clear, but
why is it not
NG
showing
of the
you?
case.
Let's start the.
Orange, you are requested,
Please
Orange, you are
continue.
requested to mute your phone.
So we went ahead where we are
Okay.
in this case, put an
So,
impella.
I'm sorry for the
Here's an
technical delay.
So we have lost
We have to move on with the
your
talk for
voice,
now,
we have
and
lost
then
the
we'll see
Yeah,
if
I
we
hear a
can
lot
figure
of
out in the
echo
later
any visual
part
from
Yeah,
your
technical
center,
issues.
Ehtisham.
So the first
Can you
talk
see the
is
image?
going to
Maureen,
No, no,
be
we can't see.
can you please
by
mute
Dr.
your
George
phone?
Angus.
And the
Maureen?
Can you please
has
start
a
the
proximal
case and
lesion,
just
right
show
to
us
left,
NGOs if possible?
collateral.
He's very well known.
On the echo,
He's going to
she's
be the
got
SPY president
inferior
elect as well.
acanesis,
And Ehtisham, can you hear us? One of his,
hypokinesis of the anterior and lateral
I would
wall.
say
I can hear
students.
you. Can you guys hear me? Let me
Asad
just
is
show you
sitting
what
here
we've
as well.
done.
So we're going to go ahead with his talk, and then we'll
Can you
come
hear
back
me,
and
everybody?
see if we can figure out
Yeah,
what's happening with
not too clearly, but still, now at least we can hear a bit of you. So it's a 74
Okay,
years
well, I'm going
old.
to show you
Yeah, yeah.
74-year-old ischemic cardiomyopathy.
We have
Anybody
lost-
hear
And
me?
it's not showing you
Just show us, just show us
So
the,
ask
not
this
very clear,
question, why is it
but
not
NG
showing
of the
you?
case.
let's start the.
Orange, you are requested,
Please
Orange, you are
continue.
requested to mute.
Mount Sinai, but also as a president-elect of the Society of Cardiovascular Angiography and Interventions. And I'd like to congratulate you for organizing this great meeting. I'm going to talk to you about left main, of course, but some other aspects, the DAPT de-escalation strategy that can be figured out in patients with left main disease PCI. As you already heard in a set of great talks, and we'll hear after me as well in the discussions, left main is a little tricky because there's just so much at stake. And also, more importantly, particularly with the distal left main, the plaques are contiguous with either the LAD or the circumflex. Therefore, whenever we do stenting, etc., then we always have to be mindful of full coverage, of a great result, and again, be cognizant of what our patient may encounter later on and how the medical therapy can be amended or simplified in case other clinical problems arise. So no question that everybody does left main PCI, they have in mind strong antithrombotic therapy, strong antiplatelet therapy early on in order to really have a great acute and subacute result. So everything about antithrombotic therapy now in the longer term and in the follow-up, it's all about evaluating the ongoing bleeding risk and the ongoing, if any, residual thrombotic risk, and see how we can either employ something like very long dual antiplatelet therapy in case we have patients with ongoing problems of thrombotic risks due to perhaps combination of carotid, perivascular, and coronary disease, or many other lesions or special circumstances. And in case this risk-benefit ratio is more towards bleeding, could the dual antiplatelet therapy be simplified in some way in order to benefit our patient? So what's de-escalation about? De-escalation means that after the acute phase, that you really need the dual antiplatelet therapy at high intensity, could this intensity be turned down a little bit, be sort of simplified? There are many ways to do that. One of them is simply to cut one drug. So in many ways, the single antiplatelet therapy is a form of de-escalation. However, there are other ways you can do de-escalation, aside from just stopping the aspirin, let's say, as I said right above. After a few months, you can stop the P2Y12 inhibitor, or you can affect the dosages of any of these medications later on. So you start with a standard dosage early on, and after some time, you turn it down. And of course, one of the criteria you can turn this down, you can turn it down based on a platelet test or based on a genetic test, or you're just going to turn it down on everyone just as an unguided de-escalation, so to speak. But in theory, these are all the possibilities that de-escalation really covers. And what's the rationale? There's a pathophysiologic rationale for it, and it's depicted here. We have local ischemic events, plaque progression and destabilization, and then we have the longer-term prevention of systemic events, as well as the longer-term bleeding problems. Well, the first couple of them, the local and early-on events, are sort of front-loaded. So there's a lot of risk over the first month or so. But then the latter two, the prevention of systemic ischemic events, particularly multiple territories, and the bleeding events, they're really longer term. And essentially, it's a battle that is in depth of time. So what does this mean? Briefly means that early on, we really have a lot of thrombotic risks. Later on, we continue to have bleeding risks that don't go down. So naturally, one can just look at this graph and say, you know what? Why don't we dial up or escalate the antiplatelet therapy early on, and then we dial it down later on, or de-escalate it if patient's doing well, and I'm very concerned about the longer-term bleeding risk. That is, in simplified way, that's why we're considering this. What are the different options? As I said, on the left side, you can see the standard antiplatelet therapy. We have the aspirin de-escalation with a planned stop of aspirin after a month or so, or a planned de-escalation of the two P2Y12 inhibitors by just stopping them after a few months, or switching to a lower potency P2Y12 inhibitor, like either ticagrelor or prasugrel becomes clopidogrel, or you decrease the dose. So the prasugrel or the ticagrelor are continuing, but at a lower dose, maybe half the dose. The ticagrelor can become 60 twice a day, or the prasugrel can become 5 instead of 10 milligrams daily. And of course, you can do also a testing, as I said, the platelet testing and a genotype testing, essentially to verify that a patient is well responder to clopidogrel, and then avoid the more potent agents in specifically those patients. So this is a schematic of all the possibilities around the de-escalation. How to de-escalate, and particularly also sometimes how to escalate or how to initiate an alternative antiplatelet agent. It's a little complex to go through all the possibilities, but you can see the 2017 paper that includes all the possibilities. Essentially, the more important is when you're initiating clopidogrel, after discontinuing the ticagrelor, you have to load with clopidogrel, 300 or preferably 600 milligrams. Where the prasugrel and the clopidogrel have a similar mode of action, the pharmacodynamics, of course, more potent than the prasugrel. The ticagrelor has very different, and it's a concentration base that's going to rapidly decline. So you really need to load the platelets with clopidogrel when you're de-escalating in that direction. Regarding the platelet function and genetic testing, I think one can say, of course, both of them are somewhat expensive. Perhaps the genetic testing more expensive in different areas of the world, and someone needs to evaluate those possibilities. The easy thing is that the genotype testing, you can just order it as a blood test, and then the result comes later. The platelet function test, the result, you get it immediately, so you can act upon immediately. On the other hand, you have to have a setup machine, etc., in your own laboratory in order to be able to do it, or the cath lab, as I should say, in order to be able to do it. There are several meta-analyses. I'm just going to give you a glimpse of the latest meta-analysis that we performed that indicates a clinically, I would say, interesting aspect, because not only do we analyze many studies, a large number of studies about bleeding as about major adverse cardiac events, and we found a consistent decrease in bleeding with no effect, or even better, major adverse cardiac events with de-escalation. We also found that the unguided, the simple de-escalation, so to speak, seemed to work out better. Why is that? Perhaps because it was simpler to do, and perhaps errors or mishaps were happening when you try to interpret genetic or platelet testing, and for whatever reason, they weren't really happening. So this is what we found, and you can see the European Heart Journal paper a couple of years ago that solidifies that unguided simple de-escalation is actually easier applicable, gives lower bleeding, as well as great results about MACE, no concerns at all. Specifically with left main disease patients, there's one study that had a lot of left main disease patients, and this is the Korean study, host-reduced polytech. And you can see here the summary as well as a relevant paper regarding the complex PCI that did the escalation had again tremendously good results. You can see the bleeding events regardless of the PCI complexity were much more dropped down. You can see at the bottom of the slide the complex PCI had a de-escalation risk of MACE of 0.88 and a non-complex PCI 0.81. So no concern at all for the left mains and other complex PCI cases about de-escalation. In this particular study, the de-escalation was done by reducing the dose of prasugrel for 10 milligrams to 5 milligrams a little later after the PCI. And they consider the results in 1 month. So essentially, there was some difference of about 11 months in the de-escalator versus the routine dual antiplatelet therapy. The bleeding was reduced regardless. So in some ways, the simplified unguided de-escalation with a potent PD-112 upfront and a reduced dose later on might work and serve very well the community of the complex PCI patients, including some left main cases in this particular study. I think very, very reassuring and very, very pertinent to your conference. In conclusion, de-escalation, first of all, commonly occurs and occurred all the time in clinical practice, even before it was studied. Why? Because initially it was quite frankly driven by cost, a cost reduction, a cost containment. Routine de-escalation for anyone should not be recommended at this time, but could be considered. I don't think that I'm de-escalating everyone up front at the time of PCI. The de-escalation is a decision that you take at the 1 month or at the 3 month or at the 6 month follow-up visit after the initial PCI if everything goes well and there's no problems. And the benefit is to reduce the morbidity from follow-up bleeding. Interestingly, there were no concerns about increasing MACE in any way, and the modes of de-escalation was to either convert a potent inhibitor to clopidogrel or reduce the dose of a potent inhibitor, or simply reducing stopping one of the two drugs anyhow. There were considerations about the platelet functional genetic testing, but looks like the de-escalation, unguided de-escalation should be simpler and more beneficial. When you're switching the drugs, you need to really be sure if you need to load or take special measures, and that's why I offered the guide in one of my slides for this particular aspect of this clinical practice. I'd like to thank you so much for your attention and remind each and every one of you is a candidate for international membership in our Society of Cardiac Angiography and Interventions. Then you can see the 2 upcoming conferences. One is just next month in Phoenix, Arizona, but most importantly, you can plan from now for next year, May 1, near Los Angeles at Long Beach, California. So long, and thank you so much for your attention.
Thank you very much, Dr. Dangas. We are going to go ahead and move on to try to see if we can see the case from Dr. Ehtisham again. And we'll talk about question answers later on. Dr. Ehtisham, you're online. We can see your images now. You're working. So can you hear us? Dr. Ehtisham, can you hear us?
Ehtisham, can you hear us? So it's as far as we saw, it's a 74 years lady with chronic kidney disease and obviously ischemic cardiomyopathy, low ejection fraction, and then we can see this ostial left vein followed by ostial LAD maybe, and impeller being there, and now is wiring this. It's a femoral approach, so that's all we can see right now.
Dr. Ehtisham, can you hear us?
I can hear you. Can you hear me?
आवाज का Can you hear us, Ehtisham?
Ehtisham, your audio is off. We can't listen to you.
Can you hear me now?
Yes, we can hear you now.
Okay.
Not very clear.
All right. Let me just show you where we are. So, as you all recall, 74-year-old ischemic cardiomyopathy, EF 25 to 30,
Now it's better.
CKD with the creatinine of 2.
Yeah.
We went ahead and got a single femoral access, placed an impella CP. There's an osteal left main. There's long LAD, prox circumflex into the obtuse marginal. The LAD's mid-vessel occluded, and we also have a prox right coronary lesion. This is a 7 French 3.5 guide catheter. We're using bivalirudin for anticoagulation. We use a Xi'an black to cross the LAD over a microcatheter, switched out to a wiggle. We pre-dilated that with a 2015 emerge. Up and down the LAD. We went ahead and put a run-through wire in the circumflex OM and dilated that with a 2.0 balloon. Then we went ahead and did intravascular ultrasound of both the LAD and the circumflex. I wanted to show you here. Hopefully everybody can see.
Now we can hear you quite well. Ehtisham, what's the status of right coronary artery in this patient?
Good. Can you see the images as well?
Yeah, now we can hear you nicely, and we can see the images also.
Oh, perfect. So the right coronary artery has a proximal 75% stenosis with right to left circumflex collaterals, but the distal left circumflex territory we feel is infarcted. On the echo, the inferior wall was akinetic. And the anterior and lateral wall were severely hypokinetic. So we've dilated the LAD and circumflex. And here what I wanted to show you is when we did intravascular ultrasound, it's a diffusely diseased vessel, but that particular spot is angiographically calcified and on IVUS at a 360-degree calcification.
So is it a
IVUS
superficial?
of the Go ahead.
Is it a superficial calcium?
It's actually pretty deep. I was going to use shockwave, but then time was of the essence, so I went ahead and put a 2.5 NC balloon at 22 atmospheres, and it finally yielded. So the much more cost-effective strategy after I've spent all the money on the impella. And we went ahead, this is, I think, when you went to the talk, so we put a 2.538 Xiant stent. And this is followed by a 3.518 Xiant stent. Then we went ahead and went caudal, and we just put in a 2.2518 Xiants, and that's where we're at right now. So our plan now is we've gotten our LAD CTO opened up. We have the mid LAD stented to back to the prox. We've got the circumflex stented distally. Here's what it looks like angiographically at this point. And I would love to hear from the panelists and everybody else what approaches we can take.
Yep. The mid LED stent looks a bit underdeployed. We have got panelists here with us. You know, it's Dr. Asad Khan, General Kiani, Numan Nasir, and Tariq Shafi. So, panelists, over to you. Do you have
I
any
think
questions
maybe,
before?
if you don't mind, we can ask the panelists online. Maybe
And
Dr.
we can,
Abbott, Dr.
uh,
Abbott, if you
do we
would like
have
to give any
Dr.
comments.
John Abbott?
Yes. We need to cover the ostial left main as part of the approach. It appears that the ostial circ is relatively free of disease, but Shami, I don't know if you can comment on the Medina classification here, whether it is, how involved the bifurcation versus, it seems to me you're going to have a strategy of LAD stent back to the ostial left main, and then the way you treat the circumflex will depend on the involvement there at the ostium.
Agreed, Don. So we felt it was a 0-1-1. The osteal circumflex, the angios you're seeing now are post-predilatation. So our plan up front was that we needed to stent both the LAD and the circumflex ostia all the way back to the left main. And then, of course, there's the ostial left main. The mid-body of the left main is actually not that diseased, but I don't think I want to leave any segment alone. So we're going to quickly post-dilate the LAD. Let me show you what that looks like, and then we'll decide on how to stent this bifurcation. So actually, maybe we'll wait on that. Let's go ahead and do the bifurcation while everybody's here. So
what's
let
the
me
viability?
first go ahead with what we'll do is take a 4015 NC emerge and a 3523 Zions.
Ehtisham, we have.
So my plan is to stent the circumflex ostium all the way back with a 3523. We'll crush it with a 40 NC emerge in the left main and LAD. And then we'll go ahead and stent the left main.
Ehtisham, we have Dr. Chen here with us on panelists. We would like him to say a few things before we move on.
Yeah, good morning.
Xiaoling, it's great to hear your voice.
Yeah.
Tell me, what do you think?
Xiaomi, can you hear me?
I can hear you, yes.
Congratulations to your great case. Angiographically, according to the definition criteria, so this left man could be classified by a simple bifurcation because they very mild stenosis at the circumflex. So personally, I prefer to use a one stent technique from LAD to fully cover the ostial left main. Thank you.
So, sorry, Xiaoling, I just heard you at the very end about the one stent covering the ostium of the left main. What was your earlier part of the question?
Yeah, I don't think so because left main is pretty short than 10 millimeter, I think. So I prefer to use one stent. So what's your strategy?
Yes, so my plan is in the left main. I agree. So I've stented the LAD all the way back to that, from the mid to almost prox LAD. So my plan now is to go ahead and first have a balloon in the left main, and we'll stent the circumflex. Then we'll put a single stent that covers from the ostium of the left main all the way into the LAD.
Okay. So this is the balloon.
What do you think of that?
This is the balloon in the circumflex, right? It's a gel balloon.
This is now a stent. So this is a 3523 stent in the circumflex, and I'm going to take a 4015 or 20 NC emerge. What do you guys have?
I'm sorry.
420, we'll take it. So we'll put the 40 balloon from the left main into the LAD. And Xiaoling, maybe you can comment on this because I generally am pretty aggressive on using a large balloon to crush the side branch stent as opposed to being conservative on that size.
You are the master of DK crush.
Ramesh, Ramesh, do you have any comments? Dr. Raghavati, are you there?
Dr. Ramesh, can you hear us?
So So any other comments from any other panelist? Dr. Tariq Shafi, how would you do anything different?
So here we
In
go. We're
reality,
going.
it's,
It's not on the left yet. Let's go to fellowship.
it's eccentrically
Just another
and at the
data.
same. I would like to do
So hopefully all
lead
of you can
preparation.
see this. We've just
Nothing
got our circumflex stent. Obviously, we want to overlap it, and let's get the guide in.
Now, Shami, you've already imaged, so you know the sizes of all the stents. So for the balloon
got
for
it.
crushing in the left main, I would use 1-to-1 size to the left main to assure adequate crushing of the stent. And it looks like you're back about 3 millimeters, maybe just a, few millimeters or even a nano DK crush.
Yeah, usually the protrusion of side stent is around 1 to 2 millimeters. That's enough.
Yeah, so I'm feeling pretty good about that right there. It's overlapped and it's back to where I want it. So this is the circumflex stent, not quite yielding, fluoro. Oh, it was a little tricky there.
Yeah, looks like calcification.
We IVISed, it was calcified, but I didn't think it was that calcified. So I'm now at 16 atmospheres.
You pre-dilated it as 2.5 NC? This circling?
I did, yep, 2.5 NC. So,
Yeah, you could probably pull it back and go up to higher pressures.
that's the plan. See, I knew Ramesh, I recognized that voice back about a second.
Yeah.
So
Yeah, I
that's
think-
the next,
Yeah, you can also
No, not
switch
that
out
one.
to an
Not that.
NC balloon, before you go ahead and do the crush.
agreed. So let me try this. If this doesn't work, then that's exactly what I'll do. In a little bit on this one.
I see
You
a
have
good,
the OPN, Shami?
I don't have it.
Yeah, do you guys have the OPN in
At the shop?
Pakistan?
The
Yep.
sham is OPN available in US?
yeah, we just got it now, OPN, and it's just been approved about, I think, if I'm not mistaken, 2022 September, October.
Let's take it out. We'll take a 3512 NC, please.
Yeah, I
All right,
think
so we're gonna-
it adds to the options for acute stent under expansion. Certainly we don't want ablative therapies. Often if we end up in this situation and high pressure NC doesn't work, obviously OPN's a newly available in the United States. I think learning how to use it without risk is what we're trying to figure out, sizing it a little bit small and, making sure it's not oversized.
Well, I'm gonna try the 3512. If it doesn't work, I'm gonna shockwave this.
Yeah.
Yep.
I think, yeah, and shockwave is an option. It might affect the drug to some degree, but certainly better than leaving it under expanded. And other option would be laser.
At the
So
sham,
in the acute setting, like right now, is that, does everybody agree with this approach? 3512 NC, if it doesn't yield, we'll take a 35 shockwave?
Yeah, I think in the absence of having the OPN shockwave, yeah.
All right, so my team, get ready, IVL 3512.
What size balloon did you pre-deal with?
25 NC.
Yeah, I think that's the issue, probably just too
Yep.
undersized.
Yeah. So for the IVL, I try to see what is the EL to EL on the IVUS and size it by that, especially when you have an underexpanded stent. Do not size it based on the lumen.
Well, here we go with a 3512. I'm starting to feel pretty good.
So John, as we discussed this very early morning, so now Xiaomi is doing optimized side branches stent. I think this is very important for optimizing side branches.
That's at 22 atmospheres. I'm feeling pretty good. We don't need IVL, man.
So it's 3.512
Good.
NC at 22.
I'm sorry?
It's 3.512.
That was 3.512 at 22.
Ehtisham, what's your strategy to reduce the risk of this further kidney injury? How much dye have you consumed and any pre-procedure preparations for that?
Yeah, good question. So when we measured EDP, it was 24 today, and that's a good question. And maybe Don, you can and others can comment. One of the questions that we're trying to answer out of the Protect 4 study is there value in the use of hemodynamic support, specifically Impella, to preserve renal function. So obviously we're trying to limit the amount of contrast we use, but the other element of it is that very question to answer. Hemodynamic support, specifically with Impella, doesn't actually protect the kidney. As far as contrast is concerned, I am trying to limit it. It's one of the reasons I didn't do the right coronary today. So we are now going to go ahead and so again, another question I'd love to ask the group. Let's put the balloon in first. So we're going to put a 4-0 balloon first across, and then I usually pull my side branch wire out at this point, as opposed to leaving it in. I've heard some people tend to leave it in. What do most people do?
So you always take this side branch wire out, but we have seen so many of
I
experts.
always do.
But we have seen so many of experts keep this wire in. So what's the incidence of this wire trapment with the other experts?
So that's what I want to hear.
Yeah, I think it's quite small. I mean, certainly in a non-stented vessel, I would always leave it in and leave it in for the proximal optimization. In the stented vessel, with just the first half here where you're doing the crush, I think it's perfectly safe and unlikely to become entrapped because you're really only deforming a little bit of the metal onto that wire. And, but after the first kiss and going for the stent across, then I would certainly remove it at that time because then it's metal on metal. But if it's balloon on metal, you're usually fine, no issues. But watch the guide, particularly with left main, when you're going to remove any trapped wire that the guide doesn't.
We'll take that run through wire.
The left main stent.
Thank you.
So, Don, believe it or not, after almost 20 years, I recently entrapped a side branch wire through it was a calcified vessel, sharp angle. And that was a pretty harrowing experience where it unraveled, took us forever to get it out. We were able to get it out. So that's probably what changed my practice.
Yeah, I think the calcification, angulation, amount of trapping, again, for the left main crushed, the amount of proximal stent is very, very little. So when you're doing a normal, for the crush part, for that first, the step you're on now, but later on, certainly I would remove it.
Yep. Right. So our step here is we're going to go ahead. So we've crushed our side branch, sides, and I want to make sure, there we go.
Now, rewiring this side branch in the left main in terms of the struts that you would be looking to rewire through distally, proximally. Can you elaborate on that?
Yeah, you know,
Dr. Chen?
I love that debate. Quite frankly, as long as I get the wire down, I've never adjusted it. That'll be my honest answer.
Yeah, I think anything but extremely distal is fine.
Right. So I'll take a fresh 3515 NC, please.
Personally,
Is that good?
I prefer to use non-hydrophilic wire to recross the side branch. So for
3.0 and
this case,
3.5?
for this case,
All right,
Xiaomi,
3.5 and 3.0.
so for this case, Xiaomi, I believe you rewire from the proximal cell into the thin flaps. Amazing technique.
Would you like to crush with a larger
So I
balloon?
think what we'll do,
Pot balloon?
Xiaoling, next is
Larger
we're
balloon
going to
crush,
obviously
pot
put an
balloon
NC
crush.
balloon in
Yeah,
the
larger balloon
side
crush.
branch and the
The
circumflex, and we'll
previous
put
balloon
another
is
NC
3.5,
in the left
is
main
on the side of the
LED.
left main.
And
So from my
once we do
hand, I
that
will
first kiss,
use
then
a
we're going to go
single
ahead
NC
and
balloon 4.0 to complete the
put our
crush.
stent.
Yes.
He did use a 4.
Okay.
So the traditional
Do you, how
teaching
many,
is proximal
Okay.
cell for DK
Okay,
crush
I see.
and
Thank you.
for distal cell cross for proximal
how many
cell,
cases do you use
provisional stent
imaging during your
strategy.
DK crush?
But that's it, as Don mentioned,
Left main.
Yeah,
or
right.
even
To
as we've
confirm the
seen,
crush,
take whatever you
you
get
use
there.
imaging
It will
IVUS
not spend
before
too
you
much
deploy the
time.
main vessel stent?
Absolutely.
But if you're really interested, you can probably show a stent boost to see where we are. And I think, but I agree with Shaoling, it looked like a proximal cell cross here in this particular case. And I think jailing the wire for people who are in the audience and trying to learn DK crush, it's better to follow, again, the traditional teaching is take the wire out as you have seen in the live case and don't jail it. And until you do become comfortable and maybe as an expert hands, you can probably jail the wire, you know.
I mean, what is
And
the
I think
benefit
the
of
one
jailing
comment
it
I
in the
would
crush
make is do
stent? There
not
is
ever jail the BMW.
really
I
no
know a lot of
benefit.
people
You
no longer
just,
use the BMW, but that's one wire I don't like to jail.
Yeah.
So is there any benefit of keeping the wire there?
no, not really. I mean,
I think theoretically the idea is, it's a wire out or whatever, that if you were to, you're more likely to supposedly have a patent vessel. You can see this NC balloon crossed really well, and so we're in a good spot.
You're right. So,
What are the sizes of balloon to the side branch and the bed, left bed?
Yeah, so 3.0 and 3.5. 3.0 side branch, 3.5 in the main vessel. In a little more.
Very easy to cross.
And what's the pressure?
Very easy to cross. So, which one?
The general guideline is size it 1-to-1 to the distal main vessel for the main vessel balloon and to the side distal into the side branch. NC balloons.
You have got 3.5 in the left bed, I think.
So, yeah, there we go. Let's go, come back a little bit. 3.0 in the circumflex, 3.5 in the LAD. Okay. Go ahead. We're going to both go.
NC balloon, is it? 3.5 and...
How are the impeller flows right now, Shami?
Oh, good, yeah. So Impella, it's, for a lady like this with an EF of 25, 28%, has, I think, really made this whole procedure go very, very smoothly. We've had no compromise. We're in auto. We have 3.8 liters a minute. And maybe Ramesh or Don, somebody can talk about Protect 4, because I was going to randomize this lady into Protect 4, but I wasn't sure which way it would go today, so I decided not to randomize her. But she would be a perfect Protect 4 candidate.
Sure, yeah. Protect 4 is looking at ACS presentation, non-STEMI or STEMI with multivessel disease or ongoing angina as well. And those patients
So what do you guys want to stent this with now?
are being enrolled in Impella versus standard of care, which might include a balloon pump or nothing at all. And doing a
28 or 23?
or non-left main multivessel PCI. This study is probably to help us get
These 20s?
to the guidelines.
Yeah, and I think the important part of the trial is
Or
that
28
if you're
Zions.
in the non-Impella arm and the patient decompensates, you cannot then use Impella. So most sites would have backup ECMO or another circulatory support device that's, a step up from a balloon pump.
So I don't know where we are with time, but so we've got this 3.5/23 in the circ. That was a high pressure non-compliant. We crushed it with a 4.0. There's our first kiss. We're about to put our stent in the LAD in left main. We're going to do that, then we'll pot, and then we'll recross and do our final kiss. Followed by a final pot.
And then I was.
So, Bacha, let me,
Absolutely. So we IVUS at the very beginning and we'll IVUS at the very end.
Bacha, let
My
me,
fellows have convinced me to IVUS at the beginning because Abdullah to my right, he's a second-year interventional fellow. He's almost finished. IVUS for him is now like, I don't know, it's his soother. Without it, he can't do PCI. So he's convinced me that I better start getting up to speed. Are you all using IVUS in most of your cases? Non-left main?
Every single left main and bifurcation complex PCI, CTO. I mean, rarely. Maybe skip an acute MI once in a while, but at least 80%.
So, Bacha, usually I will keep wire in the side branch before ballooning quash. But after first kissing, I will remove the side branch wire. Thank you.
Yeah, Shaolin, I'm with you on that.
Yep, I agree.
Xiaoling, I missed that comment. Sorry, what did you say?
You're going to remove the side branch wire, right, Shami?
Yes.
Yes, that's what you're saying.
First, let me just get this all positioned up. I think we're in a good spot. Yeah. So another point, I always, Bilal just pointed it out, we like to place the ostium of this in the left main in the LAO cranium.
3.5 stent? The stent you are putting it now from left main
Which
to
stent you are
LAD.
putting in at the shower? Which stent you are putting in?
Is it 3.5?
It's a 4.28 Zions that we're going to obviously dilate bigger.
So what about your choice of ultra-thin strut stents for left main? Do you use them or just go with the extra strength stents for the left main?
Yeah, I pretty much use this or the Megatron. Once in a blue moon, I'll do a Resolute. I can't, no.
More distal.
Sorry, I'm just trying to line up, trying to determine exactly where we are from an osteo standpoint.
I mean, most of the time, the left main is going to be above 3.0, so even the ultra thin are probably similar to the regular thin, the struts. I think as long as you have the correct expansion profile, that you know you can reach the diameter of the left main, then probably any of the contemporary stents that we have at least available would be acceptable. You may have additional stents that we don't have available.
It's been tricky to exactly figure out the ostium in this particular case. I've had to do multiple views.
Yeah, I was going to say you have two possibilities to IVUS from the LAD stent to the left main. If you have IVUS on a pullback to get an exact length, that would give you a really excellent, measurement. And the second thing is to IVUS mark against a bony landmark or another, something you can use that's non-angiographic if you're having trouble.
Yeah, well, you guys hopefully can all see the trouble that we're having. So I'm going to go back to my diagnostic because I was pretty sure I knew where it was.
In terms of
You can leave the wire also in the sinus and probably use osteal probe. I don't know whether you have them available in Pakistan or.
Osteal flash?
Yeah, osteal flash, yeah.
Yeah, they were back ordered. We finally got some today.
Yeah. We don't have them at all because of the back order. So.
Yeah. Panel, do you have osteal flash available in Pakistan?
Which anticoagulant is being used? Can I ask this?
Oh, which anticoagulant?
Oh, we're using bivalve.
We generally use heparin, unfractionated heparin for complex PCI and pre-treat everybody with a potent P2Y12.
You know, the part I get annoyed by, I'm going to deploy here. Everybody happy? About
If
the
you're happy.
heparin. Yeah, I think so. But the heparin part is just all these ACTs to check.
Yeah, I think if
18
you're in
down.
a complex case, having the nurse have the ability or the tech to check it every 30 minutes from another line is very helpful.
Well, Impella was great for this portion, I can tell you. Yeah. So we're just going to go up here. We will pot, and then we will.
What is the ACT you are maintaining?
You know, so with bivalirudin, once it gets over 300, we don't check it again. So what was the ACT in this case? I think we checked it early on, and we haven't checked it again. 286 is what it was.
Yeah, that's one advantage of using Angiomax. Like once it's you've achieved it, you don't really need to check it. We use heparin most of the time, so in Pakistan we have to.
So we're going to pot with a 5-0, and then we'll recross for our kiss.
Would you like to loop a second wire in the aorta for precise placement of stent at the ostium and avoiding stent crush with the second wire looped in aorta?
Ehtisham, Dr. Tariq Shafi has a question. Just to avoid this guider getting into the ostium of the left main, he is asking you if you can place a second wire and make a loop.
We could absolutely, you know, now we've already stented it, but yes, that's obviously a great strategy to just put a wire in the sinus there. So right now, we're going to quickly pot, recross, and finish with a kiss.
Yeah, because your left main is stented, so we should be very cautious about the longitudinal compromise by guiding catheter.
So was this patient preloaded with ticagrelor or something else?
I'm sorry?
Was this patient...
Were they pre-treated, Shami, with Brilinta or any P2Y12?
She was pre-treated with clopidogrel.
So are you guys doing testing?
Yeah, good question. So, you know, we did a lot of those studies early on. At this point, we are not. And in fact, my plan was to switch her to TICAG.
Yeah, I was
She came in as an ACS. She's got left main.
Yeah.
And pretty extensive stenting. So, yes.
Yeah. So this is a full balloon.
So this is a 5015 NC. We're going to pot with that and...
Sorry, Sham. So what's your usual DAPT of choice for left main? Like, do you use ticagrelor or Plavix, or is Plavix because of possibly avoiding groin complications in this particular case?
Yeah, I wouldn't say TICAG would affect my groin complications. I think we should have preloaded her with ticagrelor. That's what we should have done. But she was loaded with Plavix by the house staff, and so we just kept it going. And in fact, Abdullah here, our interventional fellow, brought up that maybe afterwards we switch to TICAG, which I think we will. We'll take a run through, please.
There is a question from the audience on interactive panel. How common you see dyspnea with Brilinta, ticagrelor, in your clinical practice? Dr. Abbott or Dr. Ragabati?
Very rare.
I'm seeing it less than was reported in the Plato trial, which was upward of 10%. I think it's pretty rare.
I agree with Don. Yeah, very rare.
Okay, guys, so as you can see, we potted the left main with a 5-0. We will now cross into the circumflex, and then we're going to go ahead and do our, there we go, second kiss. Following that, we'll do a final pot. And I think I'm probably going to need to optimize some of these distal stents with some post-dilatation, which we'll do.
Which wire is being used for recrossing?
Which wire has you
This
used?
is a run-through. You can just take it down if you want. Yeah, it's fine. Good. Yeah, press 3 up. 3.5, we'll take that for the,
So for recrossing, does it really matter where you cross?
I think, Bashir, we were just talking about that. We try and go into the proximal strut, but as I stated, my own goal is just to make sure I can get something across.
So now
So,
which balloon size you are using to cross once again?
we have a 3.5 going into the circumflex. And probably a 3.5 in the LAD. I'll take the. Perfect. So that's a 3.5. You saw how easily it crossed into the side branch there.
Xavier, nice job with the sizing in the left main.
I was just going to compliment Xiaoling Chen because I think he's made our job so much easier. I remember in the past when I used to spend a long time trying to wire the side branch and then try and find something that will cross it.
Thank you,
I think if you follow the technique well, it works quite predictably.
So did you go with an NC balloon in your circ?
Yep. It's a 3.5 NC in the circumflex. We're going to put a 3.5 NC in the LAD. We'll alternate high pressure and then finish with a kiss. Okay, great.
Both 3.5.
Back to the issues with the acute kidney injury. In the absence of other factors other than the contrast that can cause nephropathy, most people are using a cutoff of the contrast volume of 3 times the GFR. If you keep that below that threshold, you can reduce your risk.
Ready?
And for individuals not in heart failure, using aggressive hydration, you could use from the trial data, you can use
Take that 5
up to 5 cc's per kilo hydration per hour if the LVEDP is normal at the beginning of the case, under 12. And usually between 12 and 18, 3 cc's per kilo per hour, and above 18, 1 cc per kilo per hour. So aggressive hydration if tolerated and low contrast. But I think what Shami's talking about is that acute kidney injury can be contrast-induced and non-contrast-induced during PCI. So if you have hypotension, then that would contribute. And whether hemodynamic support devices can, in fact, reduce the risk is unclear. So that'll be something of interest.
So Shami,
Yeah, and that's one of the sub-studies out of PROTECT 4. And so we will answer that question. We're actually doing very detailed measures. Post-PCI, they'll get daily creatinines for 5 days. And patients take a machine home and measure it every day. So it's probably the first study where we're going to systematically look at that. He came back.
So, Ehtisham, if you could move a little bit faster, we have like 5 minutes more. We can extend to 10 max.
Perfect. You know what I'm going to do? Perfect. So, Bashir, what I'll do is we'll do this final pot.
Yeah.
And once we've done the final pot, we'll take some pictures, and then we're still going to IVUS, but because I can't transmit the IVUS, I'll let everybody go at that point. Maybe in a little more. Good. Back a little bit below. There you go.
This is 512 NC?
This is a 5.0, yes. So we're going up with a 5.015 NC. Our final pot. We're going to hit it one more time at the ostium, and then we'll take a picture. Guys, go ahead, get the IVUS ready. Oh, too far back. You got it.
Did you pre-close the femoral access?
We always pre-close the femoral access, yes, if we can.
That's a single access.
Oh, yeah. All right, so let's show you the final picture. Like I said, we still have IVUS to do, and we probably still have some post-dilatation in the distal stents to do. Let's just get a coax here. Good, nice. Yeah, actually, let me just...
You plan to do IVUS also?
We are going to do IVUS, yes. Ready? But I'll show you the pictures here.
Looks very nice.
That looks quite nice.
Looks quite nice.
Can we have a AP cranial view?
Yep, that's our next plan. So that's AP caudal, or with a slight LAO. The LAD. Abdullah, you pull the wire back. Okay, that's all right. There we go. That's good. That's good. Perfect. So here's our final AP cranium.
Perfect. Maybe you need some post-dilatation in the mid-LED stent as you have already planning, you know. Otherwise, the
Correct. I think I'll do
otherwise
exactly
the
the
results
mid-LED stent, and I think I'm happy with the left main and the proximal, but we'll hit up the rest of the LAD and then we'll IVUS.
Yeah, it's a wonderful result, you know, and the patient is well controlled on this impella, you know, maintaining the blood pressures and everything, you know. And obviously, this kidney function needs to be followed, as you say. So it was a wonderful, you know, session with you for the initial hiccups, except for that. Otherwise, all the case very went well after that, you know. And any comments from the panelist, Dr. Chen? Any final comments?
Yeah, so far I have no more comments, but after I was, probably we need to do more post-dilation for proximal AD.
Dr. Ehtisham, my final question to you would be, you know, in this case you opted for a DK crush. What are your preferred strategies to Dr. Abbott as well and Dr. Ramesh also? Whether, you know, Europeans, they are more fond of this Q-lot. What about any role of mini crush in the left main stenting, and or just you go straight away with DK crush as your preferred choice?
So I'll just quickly answer and then others can. My preferred choice is DK crush, but if the side branch is relatively, you know, limited in its disease, like a focal disease, I'm not averse to mini crush or Coulot. It depends on the anatomy, but I would say for the vast majority of cases, DK crush is our preferred approach, and provisional we only use if the side branch is spared of disease.
Dr. Abbott and Dr. Ramesh?
Yeah, I think for true complex bifurcation disease, according to definition criteria or similar other simplified criteria, I would go for DK crush, but if the angle is more right angle, could be very small, like nano crush, more like a T. I don't favor the culotte as much. If I'm going to use a culotte, I would certainly do a DK culotte and make sure by imaging I've done a good job, but I have no trouble doing a provisional if there's simple bifurcation in the left main, if it's optimized.
You know, because this DK crush, you know, you go with multiple balloon inflations, more dye, So that was actually one of the reasons I asked you questions in this case as well. Dr. Ramesh, any comments, final comments from you?
I think he had to run and get a call.
Okay,
But,
thank you.
I do think most of the steps of the DK crush can be done with no contrast.
There is a question from the audience. Dr. Anjum Rana is an interventional cardiologist here. He
Because
wants
in
to ask a
white-
question to Dr. Ehtisham.
Thank you. Sir Ehtisham, because this contrast and issue is under discussion, bifurcation, if you want to go for a zero contrast in some case, so which strategy of bifurcation you will select in your patient? If you want to go with absolutely zero or near zero contrast for like doing only one final shot?
Yeah, that's a really good question. I would say that if I was truly going for zero contrast, I would, with a final approach only, that's where I might prefer a provisional approach. But if I do have to do the side branch and provisional, the truth of the matter is, you don't need a lot of contrast for DK crush. Once you start laying down the stents, you don't necessarily need to do a lot of angiographic images.
So thank you.
So,
Yeah,
for the-
Sorry, I just want to ask.
You don't really need to take pictures in between the initial placement of the stent and the final kiss. You know, especially if you've IVUSed and you know the length of your main vessel stent and the length of your side branch stent, you don't really need much dye.
Okay, there are some case
Actually,
reports
for
on-
the interest of the audience tomorrow, we'll be having case presentations with zero contrast. Yes, Jal Kiani is there. He has a question.
Question to Dr. Ehtisham. This is Dr. Zakari. Ehtisham, what are you going to do about the distal LED?
Distal LED, yeah, good question. So as you can see, we're now optimizing our stent in the mid LED. The distal, this whole thing was occluded. And so I think that what I'm going to do is not chase myself any further and see how it remodels. And hopefully some of it will remodel in our favor. But good question. I don't think I want to stent any further down.
So was there a heart team discussion before you picked up this case?
Yes, so I did the diagnostic 3 days ago. We had the surgeons. We actually did 3 cases that day, all of which I wanted to do PCI. All were multi-vessel. They took the 2 easy ones, and this is the one we're left with in the cath lab.
So I think that's it. And we are really thankful to you, Dr. Ehtisham. You are a wonderful operator, and we are so thankful for you and your team there at San Diego for being with us. And you were the first one getting live this morning. It was a wonderful experience. Thank you very much, Dr. Ehtisham, all the team from San Diego.
Great. Well, thank you for having us. We really appreciate the invitation, and I'm sorry I couldn't be there, but next year I will.
Thank you so much. It was an excellent case, an excellent demonstration of the DK crush technique. I think just a few glitches in the beginning, but later on everything went very well, and I'm really grateful for that. Dr. Abbott, I know it's too late after midnight for you, and I'm really grateful that you were able to be here despite being there that late. So if you have to leave, that's fine. You can leave. Thank you very, very much for being there with us.
Thank you, Dr. Abbott. So now, we are back for the talks. And for the next talk, I'll request Dr. Asad Khan to introduce the speaker, because he has worked with him. And this is Dr. Annapurna Kini. And over to Dr. Asad Khan to introduce the speaker from US. Dr. Asad.
Yes, it gives me great pleasure and honor to introduce Dr. Annapurna Kini. She's the Professor of Cardiology at Mount Sinai. She's Director of Cardiac Interventional Cardiology Program, the Structural Heart Program for the entire Sinai Health System. And in addition to all that, she is the highest volume female operator in the US. She has the best safety record for the last 12 years in New York for complex coronary interventions, and probably very well published as well. So all to you, Dr. Zubair.
So over to Mount Sinai, and it's Dr. Annapurna Kini to deliver the talk. The topic of the talk is best strategy for left main bifurcation in year 2023. Over to you, Dr. Kinney.